Can you guys hear me? Can you hear me? Okay. It's great to have a successful mother, except you always hear about her everywhere you go. Follow her, but that's great. If anyone ever asks you to speak after Dr. Gertz, say no. That's a tough act to follow. My name is Nisha Joseph. I'm one of the members of the myeloma team at Emory. And I was kind of tasked today to speak to you. I'm going to repeat a few of the things that Dr. Gertz has already talked to you about, but I think that's good to hear things more than once anyways. And I'm going to talk to you a little bit about how we establish a diagnosis of myeloma, how we then start treating newly diagnosed patients, some of the things we want to make sure we're doing up front to kind of set you up for the best response, the best long-term outcomes. If there's any questions along the way, please feel free to interrupt me. So kind of the outline today, what should and shouldn't be done in a newly diagnosed patient, how we establish the diagnosis, how we approach therapy generally, broadly in a newly diagnosed patient. That's going to be delved into more as we go throughout the day with some of my colleagues. And then we're going to talk about the role of transplant, how transplant works that Dr. Gertz has talked to already, and then touch a little bit on supportive care, so other medications and things that we often give patients during their induction phase to protect them against some of the complications you can then have from your therapy itself. So who develops multiple myeloma? About 2% of all cancer cases in the US. In 2018, there are about 30,000 new cases, a little bit more predominant in men than women. And risk factors can be hard to tease out because we're looking at people in their 60s and 70s and looking back over the course of their life and trying to figure out what happened. But what we do know is it's more likely the older you get. And we do see a higher incidence in African Americans as compared to Caucasians, about 2 or 3-fold higher. And this is data, again, just looking at the predominance based on age. You can see that the median age of diagnosis is around the mid to late 60s, early 70s, excuse me. Kind of drops off the younger you get, but we see myeloma at all ages, and we even have a few patients. I had a patient last week who was 21 with the new diagnosis of myeloma. So this is referencing a little bit what Dr. Gertz was speaking about the spectrum of disease and plasma cell disorders. So you have, when I think about plasma cell disorders, I think on one end we have MGUS, monoclonal gammopathy of unknown significance, to smoldering myeloma, and then to the symptomatic disease, multiple myeloma, or symptomatic myeloma. And so everything kind of on that side to the right, I think of as a precursor state. And so as we kind of move from MGUS to smoldering, you have more and more of these weeds producing more and more of the protein, but you're not getting this myeloma-defining events or these end organ damage in the patient. And what we refer to those as is CRAB criteria, which is an acronym for the 4 symptoms we look for in patients to see if they're symptomatic from their clone, from these weeds and the protein they're producing. One is high calcium level, C. R is for renal dysfunction or kidney issues. A is anemia or the low blood counts. And B are the holes, I'm not supposed to say holes, but holes in the bone causing fractures or bone lytic lesions in the bone. And so once you start having those symptoms in the body, we call this symptomatic myeloma, and this is when we start treating the patient. And whenever I think, these are plasma cells here that he was referencing in the garden, when you take that bone marrow aspirate from your back and we look at it under the microscope, this is what we're looking for. These are plasma cells. These large cells, I think they look like fried eggs, they're blue, they have nucleus kind of on one side. And whenever I think of kind of clonal plasma cells, it makes me think, I don't know if anyone has seen The Matrix, but it makes me think of Agent Smith. He's basically a bad actor, makes a clone of himself and starts causing problems in the body. And or causing problems with Neo. So that's what I think about when I think of myeloma. Oh, sure.
Somebody here to work on the audio.
I'm sorry. Is there anything I can do on this?
Is it on? Get the mic closer to your mouth.
Well, I'll just hold it. Is that better? I'm sorry. Yeah, that's much different. I'm very sorry. What about now?
That's okay.
All right, I'll just hold it. It's all right. So because we're looking for symptoms, myeloma is largely a clinical diagnosis. So this is a good kind of visual example of what Dr. Gertz was talking about with a bone fracture. So what you have here on the far left is a patient is walking around doing what they normally do. They lift their grandchild. They put something in the trunk, something they've done before without issue. But now because of these these holes or these damage to the vertebra in the back, very small, minor activity can cause a compression of the bone because it's not able to hold up the weight that it's supposed to. So you can see on either side, you see a normal vertebra, and then you see all these cracks and holes causing the vertebra to compress down upon itself. And the second image here in the left is actually an MRI. And so you can see above and below, you can see that's what a normal vertebra looks like. That's the building block he was talking about, that kind of white box. And in the middle is the compression fracture where you can just see, you can't really see much bone anymore. The vertebra is compressed down on itself. And when you take a biopsy of that lesion, that's when you see all these plasma cells under the microscope, and you start to think, this is myeloma that's causing these issues. These are other examples of what lytic bone disease can look like. On the left, that's in the skull. You see that large kind of black area, that gelatinous space, that hole. And even on the left there, that's in the arm bone. You see those black spots is what he was talking about, as opposed to the white, strong of the bone. And it could be very little activity that caused then a fracture and caused a lot of pain and problems for the patient. So this is kind of the technical criteria for how we distinguish MGUS from smoldering myeloma to symptomatic myeloma. So MGUS here, we think about a small amount of weeds in the bone marrow, a small amount of clonal plasma cells, a small amount of protein, and no CRAB, so no symptoms in the body. Then as we move to smoldering myeloma, we have a little bit more protein, we might have a little bit more weeds in the garden, but we're still not seeing symptoms in the body. And then multiple myeloma, like Dr. Gertz mentioned, you have more than 10% clonal plasma cells, and now we're starting to see symptoms, and we need to start treating this. Now the caveat to this is there was an update to the diagnostic criteria of myeloma a few years ago, but when we looked at patients who were previously classified as smoldering myeloma, we saw a subset of patients who had enough disease that their risk of progression at 2 years was quite high, and that they would benefit from treatment earlier. So we moved these patients from the category of smoldering myeloma into myeloma, even in the absence of CRAB criteria. And these patients are listed here under the red line, are patients who have clonal plasma cells greater than or equal to 60% in the marrow, a serum-free light chain ratio, so that's saying that one of your light chains is that abnormal that it's 100 times greater than the other, or you have more than one focal lesion on MRI or PET-CT indicative of early bone disease. And so these patients are now classified as having symptomatic myeloma and benefit from treatment now. So I just wanted to mention a little bit about smoldering myeloma because I don't know if it'll be mentioned later today. This is a very heterogeneous subset of patients because, as you can imagine, you have patients that fall in this category who might have 15% plasma cells in their marrow and a small M protein, and this is in the same category of someone with 50% plasma cells and 4 grams of protein, but they're not having symptoms, so they're all in the smoldering category. So we really have to be cognizant these are not all the same patients, and some of these patients might benefit from earlier intervention. And so recently, new risk stratification criteria came out for smoldering myeloma, looking at 3 things. One is how big is the M protein? Is it greater than 2 grams? How many plasma cells are in your marrow? Is it greater than 20%? And how abnormal is that free light chain ratio? And so for each one of these criteria that the patient meets, they get a point. So if they have 0 points, we call that low risk smoldering myeloma. If they have 1 point, it's intermediate risk smoldering myeloma, and 2 or 3 points would be high risk smoldering myeloma. And this correlates with the likelihood of progression at 5 years. And there has been recent data presented and soon to be published on treating intermediate and high-risk smoldering myeloma, and that there does seem to be some advantage and a delay of progression to symptomatic myeloma when treating these patients early. So this continues to be an ongoing area of clinical investigation. So we talked a little about precursor states. I'm going to move to a patient case. This is my patient, Bob. My husband is a huge Bob Dylan fan, really obnoxiously huge Bob Dylan fan. We have Bob Dylan photos all over our house. I have a Bob Dylan clock in my family room. And so whenever I give a talk, Bob is my patient. Although my husband doesn't like it. He doesn't like that I give Bob a health problem, but what can you do? Can't kill this guy. He's going to live forever. So Bob is a 66-year-old musician, and he comes into my clinic presenting with worsening back pain and fatigue. So his hemoglobin, which is the red blood cell count, is low, lower than what it should be for him. He has an elevated IgG, so that's that type of protein in the blood. And when we look for the M protein, it looks like he has 1.3 grams of IgG kappa. When we do a bone marrow biopsy on Bob, he has 20 to 30% clonal plasma cells on the bone marrow. And we get a PET CT or scan of his body, and we see these lytic bone disease, these holes all throughout his spine and skeleton. So by definition, Bob has myeloma. So what do we do? So some things I was thinking about, one of the topics is how to get off on the right start. What are things we really want to make sure we get right at diagnosis? And one thing, having seen a lot of patients who are diagnosed in the community and come to us, we want to make sure we have the right diagnosis. Because it can be tricky sometimes to distinguish, particularly between smoldering myeloma and myeloma. And so I'll give you an example. One of the things we look for in the CRAB criteria is renal dysfunction. The important piece there is to make sure that the renal dysfunction is attributable to the underlying plasma cell disorder. So sometimes we see patients who have uncontrolled diabetes or uncontrolled high blood pressure, and they come in, that can cause abnormal kidney function. And so through the process of working up this kidney function, they're also found to have a small plasma cell clone. And so the question then is this kidney dysfunction because of the plasma cell clone, or is it because of their diabetes? And we want to be real sure that we're getting that diagnosis correct, because we don't want to expose you to treatment that wouldn't actually help what's going on. Does that make sense? Okay. Anemia is another one we see, particularly of women who are still menstruating. We want to make sure this is not iron deficiency or something else that's going on. This is really because of the myeloma. Once we do have the correct diagnosis, we want to start treating right away. We want to start reversing some of this organ damage that has already started to take effect. If it's okay to share your story, I was speaking to Melissa this morning, and she was talking about her husband being diagnosed with renal failure. Came in very sick to the hospital, moving towards dialysis. We want to intervene quickly, try to prevent losing kidney function and going on dialysis, right? So you want to try to reverse some of those symptoms, make the patient feel better. Then you want to appropriately risk stratify the patient based on some of the genetics of their myeloma. And I believe Dr. Hoffmeister will speak on this a little bit more after me. And this helps us identify and select the appropriate induction therapy for your specific type of myeloma. You always want to at least talk about transplant early. You want to start planning for that early, not only from the medical standpoint, but also the social standpoint. It can be quite disruptive to go into the hospital for 2 weeks for people who have families and jobs and all sorts of things going on. You need a caregiver. For us here in Atlanta, we have a lot of patients who don't live in Atlanta, so it's a big deal to uproot your life for a month, come here for 2 weeks in the hospital, stay for 2 weeks in the hospital. So I think the earlier, I like to see patients referred to us, before they start treatment if possible. We can start having that discussion and start preparing. And then of course, appropriate supportive care, which we'll talk about. So this is kind of the general treatment algorithm that we think about for a newly diagnosed patient. So you have a new diagnosis of myeloma. Sometimes if the patient is sick, we might start 2-drug therapy that's a little bit more tolerable in the hospital, or sometimes chemotherapy in the hospital. And then once we can kind of get them in a better spot based on either standard or high-risk cytogenetics, we start therapy to start killing off those weeds. Start killing them off, start reversing some of those symptoms, start making the patient feel better. And this is called induction therapy. And this can be a combination often of 3 or 4 drugs that you would receive in the clinic. And depending on which one you'd get, this is usually a combination of IV drugs, pills, and subcutaneous injections. Following induction therapy, pending you've gotten the response that we want you to get, and that you're feeling better, we then move to transplant to try to kill even more of that myeloma and try to prolong the period of time that you have controlled myeloma, controlled disease. And then following transplant, we talk about maintenance therapy to put you on something to make sure that that myeloma clone stays quiet for as long as possible. For patients with high-risk disease, we talk more about combination strategies in the maintenance phase, just like we do up front. So just to kind of go through this a little bit more, so to talk about induction therapy, these are some of the drugs that many of you might have received or are receiving or have heard about. And again, depending on your risk of myeloma, your physician will pick a different combination of these drugs. Steroids are very highly active in myeloma, so most people, how many people have received steroids in this room? Okay. That's most people. And then a combination Revlimid, lenalidomide is another term, is an immunomodulatory agent. That's a pill, and that's given on induction therapy is usually given 2 weeks on with a week off. In maintenance, it might be given 3 weeks on with a week off. Common side effects of Revlimid, it can cause blood clots. So many of you might be, if you're on Revlimid, might be on an aspirin or some other blood thinner to prevent that complication. Another common complication is diarrhea. Diarrhea. Velcade or bortezomib and carfilzomib or Kyprolis are proteasome inhibitors. Velcade is given subcutaneously. Carfilzomib is given intravenously once or twice a week. The main side effects of Velcade are that we worry about a peripheral neuropathy, which is if you've ever fallen asleep on your hand at night, it can sometimes start like that, kind of a numbness or tingling in the fingers or the toes. Usually patients say, I get it, and then it goes away, and then it doesn't come back till I get my next shot. But sometimes the more and more Velcade you get, it can get worse and worse, and sometimes that could even progress to pain. So we monitor that very closely because it can affect motor function as well, and dose reduce or hold as needed. And then lastly, daratumumab or Darzalex, misspelled, I apologize on the slide, is a monoclonal antibody that's given intravenously. And really, that's a well-tolerated drug. The main side effect we often see is an infusion reaction, so kind of an allergic type reaction because it's an antibody. So the first time, particularly when you receive it, patients often have some kind of infusion reaction that we try to medicate through. That's why if any of you have received daratumumab the first time, it's usually a very long infusion because we give it to you slowly to give your body time to kind of adjust to it. And then usually in subsequent infusions, your body gets used to the drug. So after induction therapy, you get some combination of these drugs for 3 or 4 months. We've made a good dent in your myeloma. You've had a nice response. You feel better. Your blood counts have improved. Your kidneys have improved. Your bone pain has gotten better. And now we start talking about autologous stem cell transplant. Like Dr. Gersh talked about, it's not a transplant. We're not taking something from someone else and putting it in you. It's really just a way to rescue you with your own stem cells from this high dose of chemotherapy. And the reason we do this in patients who we say are fit, just meaning that they're able to tolerate the transplant and the recovery required with transplant, is because we know that in patients that we transplant, they have a longer period of remission or a longer period of disease control than patients that we don't transplant. And then following the transplant, like we talked about, we put patients on Revlimid maintenance, usually about 3 months following transplant. If they have high-risk cytogenetics, we might start them on a combination strategy or a clinical trial a little sooner, usually day 60 from transplant. So here's just kind of I just want to kind of talk everyone through what transplant looks like for those who have not gone through it. So as we're kind of leading up to transplant, the first step is a pre-transplant evaluation. So we want to make sure that there are no surprises once we get to transplant. So we do an ultrasound of your heart, we check out your lung function, we do lab tests, because we want to make sure that you are certainly fit enough to get through this process. Then we start collecting your stem cells. So we give you a drug called Mozobil or Plerixafor. Can you hear me? Sometimes you can or no? No. I'm sorry. You couldn't hear me before. You heard some of the last 10 minutes, right? Okay. Okay, that's good? Okay. So this medicine that he referred to called Mozobil or Plerixafor, basically stem cells are programmed to home to your bone marrow. And so this drug kind of removes that connection and allows them to slip out of the bone marrow into your peripheral blood so we can collect your stem cells. Then we give you growth factor shots, prior to the Mozobil to rev up the amount of stem cells your bone marrow is making so that we can collect them on the machine. So this is just showing your bone marrow increasing the number of stem cells it's producing. And then we hook you up to a pheresis machine and we collect these stem cells. And we collect for usually more than one transplant if we can, so we have some extras as an insurance policy. And we cryopreserve them. We freeze them until they're needed. And then at a predetermined date, you're admitted to the hospital. You're given a dose of IV melphalan, which is a chemotherapy. We give a day for the chemotherapy to leave your system so they don't affect your newly transfused stem cells. And then we basically wait. So it takes about, when you plant these new seeds, it takes about 10 to 14 days for these seeds to find the garden, set up shop, and start doing what they're supposed to do. And during that 10 to 14 day period, that's when you're going to start feeling the effects of the chemotherapy, and the melphalan is going to wipe out both the myeloma but also your normal healthy marrow. And so during this time, you're going to have what this is showing you on the left here is ANC, or absolute neutrophil count. That's a type of bacteria-fighting white blood cell count that puts you at the most risk of infection. And so during this period of time, your ANC, or your neutrophil count, as well as your platelet count, which is the type of blood cell that helps protect you from bleeding, is going to be very low during that period of time, as well as your red blood cell count. So it's very common during this period of time to need red blood cell and platelet transfusions. Almost everybody gets that. And also during this time, because you're immune suppressed, it's very common for people to have fevers or infectious complications. So you're on antibiotics to try to prevent those complications, but if you do spike a fever, you're in the hospital, we start IV antibiotics right away, do an infectious workup, although a majority of the time we don't find anything, and we just treat you with antibiotics until your counts start coming in. So this is just another way of looking at the transplant timeline. So the way we talk about every day prior to transplant is with the minus sign, and every day after transplant is a plus sign. So generally, at least at Emory, patients are admitted on day -2. That's the day they get their melphalan. Day -1 is the day of rest. And then day 0 is transplant day, where you get your stem cells back. And then we wait. And during this period of time, one of my colleagues calls this the miserable period, but it's not often miserable. It depends on the patient. But this is when you might not feel great. It's when you're feeling the effects of the chemotherapy. You might have some nausea, you might have some diarrhea and things like that. And we support you in the hospital with medicines and fluids and get you through it. And the good thing is it's temporary. The cells do start coming back in, you feel better, and once you're walking, drinking, eating, feeling good, we get you out of the hospital. Engraftment is just what we call your counts coming back into a safe range. So with a lot of the novel therapeutics that we now have, there's been discussion about the timing of transplant, early versus late transplant. And we do early transplants, and the real difference between early versus late transplant is your myeloma. So the earlier we treat myeloma, your myeloma is a little bit more sensitive to the treatments we have. It hasn't seen a lot of treatments, it hasn't had time to develop high-risk features, and we're more likely to be able to get it under control with our standard treatments. The later we transplant myeloma, sometimes the myeloma has become more aggressive, sometimes it's acquired some high-risk cytogenetics, but everything else is really the same. It's not going to change your length of hospital stay, it's not going to change necessarily the risks of hospital stay or your recovery, but it does change the amount of time that we're able to control your disease post-transplant. So that's why in fit patients that we think can handle transplant, we like to do transplant up front. So when we talk about who goes to transplant, we used to talk about age. We don't talk about age anymore. We talk about fitness. So there's really no age cutoff. I think the oldest transplant we've done in myeloma was 79. It really just depends on what that patient can do. Are they out? Are they active? They feel good? What other health problems do they have? Do they have heart troubles? You could be much older, on the older end, and be very fit, and we feel like you get through transplant well. Or you could be younger and be on dialysis, or have other uncontrolled health issues where we might worry about your ability to get through transplant. So it's really more about the individual patient and how we feel. But for most people, we try to push for transplant as long as we feel like they can get through it safely. And I'll just touch on briefly, there was a study a few years ago kind of looking back retrospectively at patients treated between the years 2001 and 2005 versus 2006 and 2010, kind of capturing this era of novel agents, some of the better, newer therapeutics we have. And even in older patients or patients who are unable to undergo transplant, they still do much better with some of these novel agents we have. So even if you can't go to transplant, we have good options to get your disease under control and keep it there. And so lastly, just some of the supportive care agents that many of you might be on or have heard of. For infectious prophylaxis, most myeloma patients are on acyclovir or Valtrex to try to prevent shingles reactivation. So if anyone has had chickenpox in their lifetime, I know I have, that virus doesn't go away. And when you go on treatment, particularly with Velcade, you're at risk of shingles, which is a painful rash, vesicular rash. So most people are on acyclovir throughout their treatment. We also often give Bactrim, particularly for patients who are on steroids for a prolonged period of time to prevent atypical pneumonias. I talked about prevention of blood clots when you're on immunomodulatory agents like Revlimid or pomalidomide. If you're already on anticoagulation, some patients already are on Coumadin or Xarelto for another health issue. We just would continue that. If not, we usually start aspirin. Bone supporting agents that Craig Hoffmeister is going to talk about, like Zometa, which has anti-cancer activity as well as helps protect your bones. And then patient supporting agents, which I made up, but I think is also important. That you have caregiver, you have family and friends, you have a support network, you come to things like this where you can meet other people going through similar things and educate yourself, because really you are really your best advocate for yourself and for your family members. So thank you so much for coming. I know there's a UGA game today, so I know some of you made a real sacrifice to be here, but there's always ESPN.com. And thank you so much for your attention, and I hope you could hear most of that. And I'm happy to take questions or
We'll do questions
at the end.
after.
Okay. All right. Thank you so much.